Welcome to the Pediatric Case Review channel. Today we will explore cerebellar ataxia in children. This lecture provides a basic overview for physical therapists, occupational therapists, nurses, and other allied health professionals. We will cover essential aspects of this important neurological condition affecting motor coordination in pediatric patients. Let's begin with a fundamental question. Which of the following best describes cerebellar ataxia? Is it A. Increased muscle tone in limbs, B. Impaired coordination of movements due to cerebellar dysfunction, C. Involuntary writhing movements, or D. Progressive muscle weakness? The correct answer is B. Cerebellar ataxia refers to impaired coordination of movements due to cerebellar dysfunction. It is fundamentally a disorder of motor coordination. The prevalence varies widely depending on the specific subtype. Cerebellar ataxia affects balance, gait, limb movements, and often speech. This is distinct from increased tone, writhing movements, or pure weakness. Let's consider this case. A 5-year-old child presents to your clinic with new-onset coordination issues. Which of these clinical presentations would most suggest cerebellar ataxia? Is it A. Rigidity, tremor, and bradykinesia, B. Wide-based gait, intention tremor, and dysmetria, C. Spastic gait and clonus, or D. Muscle wasting and fasciculations? The correct answer is B. The classic triad of wide-based gait, intention tremor, and dysmetria strongly suggests cerebellar ataxia. These are cardinal signs of cerebellar dysfunction. The wide-based gait helps maintain balance, intention tremor occurs during purposeful movements, and dysmetria refers to the inability to judge distance and range in movements. These symptoms result from the cerebellum's crucial role in motor coordination and timing. Beyond the main triad of symptoms, which additional symptom is commonly seen in children with cerebellar ataxia? Is it A. Hallucinations, B. Dysarthria, C. Sensory loss, or D. Urinary incontinence? When examining a child with suspected cerebellar ataxia, which test specifically evaluates for dysdiadochokinesia? Is it A. Finger-to-nose test, B. Rapid alternating movements, C. Romberg test, or D. Heel-to-shin test? The correct answer is B. Dysdiadochokinesia is assessed through rapid alternating movements. This examination technique tests the ability to perform quick, alternating motions, such as rapidly pronating and supinating the hands or patting the knees. Children with cerebellar dysfunction typically demonstrate an impaired ability to switch between opposing movements, resulting in irregular, arrhythmic motions. This differs from the finger-to-nose test, which assesses intention tremor, or heel-to-shin, which tests appendicular ataxia. A 7-year-old boy consistently shows past pointing during the finger-to-nose test. He repeatedly overshoots the target when trying to touch his nose with his finger. What does this clinical finding most likely indicate? Is it A. Sensory ataxia, B. Cerebellar ataxia, C. Vestibular dysfunction, or D. Proprioception deficit? The correct answer is B. Past pointing during the finger-to-nose test indicates cerebellar ataxia. This phenomenon, called dysmetria, represents the inability to properly measure the range of movement needed. It's a key feature of cerebellar dysfunction caused by the cerebellum's critical role in movement coordination and trajectory planning. Unlike proprioceptive deficits, patients with cerebellar ataxia typically have preserved position sense but cannot execute movements accurately. This test is part of a comprehensive neurological examination for suspected ataxia. Let's move to the underlying pathophysiology. Which cerebellar structure is primarily responsible for coordination of gait in children? Is it A. Cerebellar hemispheres, B. Vermis, C. Flocculus, or D. Dentate nucleus? The correct answer is B. The vermis is the primary cerebellar structure responsible for coordination of gait. This midline structure situated between the cerebellar hemispheres is critical for trunk stability and coordinated walking. Damage to the vermis typically results in truncal ataxia and a characteristic wide-based gait. By contrast, the cerebellar hemispheres primarily control limb movements. The flocculus is involved in eye movements, and the dentate nucleus is an output center. Understanding this anatomical specialization helps explain the pattern of deficits in different types of cerebellar damage. Consider this case. A 4-year-old child develops acute onset ataxia 2 weeks after recovering from a viral illness. The most likely cause of this presentation is A. Friedreich's ataxia, B. Brain tumor, C. Post-infectious cerebellitis, or D. Spinocerebellar ataxia? The correct answer is C. Post-infectious cerebellitis is the most likely diagnosis in this scenario. This is a common cause of acute ataxia in children typically occurring 1 to 3 weeks after a viral infection such as varicella or enterovirus. Unlike Friedreich's ataxia or spinocerebellar ataxia, which are genetic and progressive, post-infectious cerebellitis has an acute onset and is usually self-limiting with a good prognosis. While brain tumors can cause ataxia, the temporal relationship to the viral illness strongly suggests post-infectious etiology. Based on clinical presentation and course, cerebellar ataxia can be classified into several types. Which classification best describes ataxia that develops over years and has a genetic basis? Is it A. Acute ataxia, B. Chronic progressive ataxia, C. Intermittent ataxia, or D. Sensory ataxia? The correct answer is B. Chronic progressive ataxia describes conditions that develop gradually over months to years and often have a genetic basis. Examples include Friedreich's ataxia and the spinocerebellar ataxia group of disorders. This classification typically implies a degenerative or metabolic etiology. By contrast, acute ataxia develops rapidly over hours to days. Intermittent ataxia comes and goes with periods of normal function. And sensory ataxia refers specifically to coordination problems due to proprioceptive loss rather than cerebellar dysfunction. Let's discuss the diagnostic workup. For a child presenting with new-onset cerebellar ataxia, which initial imaging study would be most appropriate? Is it A. X-ray of the spine, B. MRI of the brain with contrast, C. CT scan of the head without contrast, or D. Ultrasound of the cerebellum? The correct answer is B. MRI of the brain with contrast is the imaging study of choice for evaluating cerebellar ataxia in children. It offers superior tissue characterization compared to CT scans and can identify inflammation, tumors, structural malformations, and demyelinating conditions that may affect the cerebellum. While CT may be performed first in emergency situations due to speed and availability, MRI provides much more detailed information for cerebellar pathology. X-rays cannot visualize brain tissue, and ultrasound is only useful in infants with open fontanelles. An 8-year-old presents with slowly progressive ataxia over 6 months. There is a family history of similar symptoms in the child's father and paternal uncle. Which laboratory investigation would be most appropriate as part of the initial workup? Is it A. Throat culture, B. Genetic testing, C. Toxicology screen, or D. Vitamin B12 levels? The correct answer is B. Genetic testing would be most appropriate in this case. The combination of slowly progressive ataxia and a positive family history strongly suggests a hereditary ataxia syndrome. Genetic testing may identify specific mutations associated with conditions such as spinocerebellar ataxias or Friedreich's ataxia. This information is crucial for establishing an accurate diagnosis, guiding prognosis discussions, and providing appropriate genetic counseling for the family. Modern genetic panels can test for multiple ataxia genes simultaneously, increasing diagnostic yield. Regarding treatment approaches for children with cerebellar ataxia, which of the following is not typically part of the standard management? Is it A. Physical therapy, B. Occupational therapy, C. High-dose corticosteroids, or D. Adaptive equipment? The correct answer is C. High-dose corticosteroids are not part of standard management for all cerebellar ataxia cases. They are only used in specific scenarios, such as inflammatory or immune-mediated causes. Standard management typically includes multidisciplinary rehabilitation with physical therapy to improve gait and balance, occupational therapy for activities of daily living, and speech therapy if dysarthria is present. Adaptive equipment may help maintain functional independence. Treatment should also address any identified underlying cause when possible. The management approach is individualized based on etiology, severity, and functional limitations. A 6-year-old child with cerebellar ataxia is referred to physical therapy. Which intervention approach would be most appropriate for this patient? Is it A. Passive range of motion only, B. Balance and coordination training, C. Strengthening exercises only, or D. Complete bed rest? The correct answer is B. Balance and coordination training forms the core component of rehabilitation for cerebellar ataxia. This approach directly addresses the fundamental impairments of the condition. Effective programs include proprioceptive training, task-specific practice, and activities that challenge postural control. Therapists may incorporate weighted vests or limb weights to provide additional sensory feedback. While strengthening exercises and range of motion activities may be included as part of a comprehensive program, they would not be the primary focus. Complete bed rest would be counterproductive and lead to deconditioning. A 12-year-old child has been living with chronic cerebellar ataxia for several years. Among the following, Which complication is this child most at risk for developing? Is it A. Hypertension, B. Diabetes, C. Scoliosis, or D. Seizures? The correct answer is B. Scoliosis is a common complication in children with chronic cerebellar ataxia. This occurs due to trunk muscle imbalance and altered postural control. Regular monitoring of spinal alignment is recommended for these children. Other important complications include falls and related injuries, joint contractures, and decreased participation in age-appropriate activities. While some genetic ataxias may have associated medical issues including seizures, scoliosis represents the most common orthopedic complication directly related to chronic ataxia. Severe cases may require orthopedic intervention, including bracing or surgery. Consider this case. A child presents with progressive cerebellar ataxia, oculomotor apraxia, and laboratory tests show elevated alpha-fetoprotein levels. What is the most likely diagnosis? Is it A. Ataxia-telangiectasia, B. Friedreich's ataxia, C. Acute cereballitis, or D. Multiple sclerosis? The correct answer is A. Ataxia-telangiectasia is an autosomal recessive neurodegenerative disorder characterized by progressive cerebellar ataxia, oculomotor apraxia, telangiectasias, immunodeficiency, and increased cancer risk. Elevated alpha-fetoprotein is a key diagnostic marker for this condition. Unlike Friedreich's ataxia, which presents with peripheral neuropathy and cardiomyopathy, or acute cereballitis, which is sudden onset, ataxia-telangiectasia shows progressive symptoms and specific laboratory findings. Recognition is important due to associated immune defects, cancer risk, and radiation sensitivity that impacts management. Regarding prognosis in pediatric cerebellar ataxia, which of the following factors is generally associated with a more favorable outcome? Is it A. Early onset before age 2 years, B. Acute post-infectious etiology, C. Presence of cognitive impairment, or D. Multiple affected family members? The correct answer is B. Acute post-infectious cerebellar ataxia generally has the most favorable prognosis among these options. Most children with this condition recover completely within weeks to months. By contrast, genetic and degenerative causes of ataxia typically have a poorer prognosis with progressive symptoms. Early onset before age 2 and multiple affected family members often suggest genetic conditions with poorer outcomes. Cognitive impairment frequently indicates more extensive brain involvement. While early intervention improves functional outcomes regardless of cause, the underlying etiology remains the strongest predictor of long-term prognosis. Thank you for joining this pediatric case review lecture on cerebellar ataxia in children. We've covered the key aspects of this condition, including clinical presentation, examination findings, diagnostic approaches, and management strategies. Remember that cerebellar ataxia is a symptom complex requiring thoughtful evaluation to determine the underlying cause, which greatly influences prognosis. A multidisciplinary approach with early intervention offers the best chance for maximizing functional outcomes. Please follow our channel for more educational content, and feel free to leave your questions in the comments section below.